This is Atonic Medical Management of Atonic Pph. A very good morning to all of you. And with Shekharan sir talk on active management of third stage of labor and uterotonics, I think I will go straight away into the protocol for the management of Atonic Pph. Atonic Pph, once we diagnose atonicity, IV bolus dose of oxytocin, 5 units, diluted in 5 ml of normal saline is given slowly over 5 seconds. Since Shekharan sir has told you in detail about this, I will not go into any further into this, but assure you, experiences over the years have shown that it does not cause oxytocin, IV bolus dose does not cause any hemodynamic instability. Simultaneously start an oxytocin infusion, 20 units in 500 ml of normal saline at the rate of 250 ml per hour. That is equivalent to 60 drops per minute. And as long as the bleeding is continuing, the same dose has to be continued. But once the bleeding is controlled and uterus becomes tonic, the infusion has to be maintained at the rate of 40 drops per minute, because once we stop the infusion of oxytocin, oxytocin gets cleared from the circulation within another 1 hour. It is very essential we maintain the tonicity of the uterus for a few more hours to go. And methyl ergometrin is as efficient as oxytocin as a uterotonic agent. In the event of bleeding continuing, or you think it is going to be a severe postpartum hemorrhage, methyl ergometrin 0.2 milligram can be given. The route, though recommended both IM and IV, we generally prefer to give it IM. We all know methyl ergometrin is a powerful smooth muscle constrictor, and the side effects being nausea, vomiting, headache, chest pain, and more than that, the much dreaded hypertension. So before giving methyl ergometrin, we have to make sure that the patient is not a hypertensive or she is not suffering from any cardiac disease. And in the event of ongoing bleeding, the dose can be repeated every 15 minutes for 5 doses maximum of 1 milligram. And then coming to the injectable prostaglandins, the injectable prostaglandin carboprost, PGF2 alpha, 250 micrograms is given IM. And again, our worry about carboprost is bronchoconstriction. So before giving the drug, make sure that the patient is not an asthmatic. And in the event of ongoing bleeding, it can be repeated every 15 minutes for a maximum of 8 doses. Then misoprostol, sir has already told its advantages. 600 micrograms is kept per rectally. And the agent which I want to emphasize is tranexamic acid. It is an antifibrinolytic agent against clots, dissolution of clots and fibrin. The dose is 1 gram, available as 10 ml, 1 ml per minute. What we do is put it in 100 ml of normal saline and finish it in 10 to 15 minutes. Fast IV. There is no point in putting it 500 ml and continuing over minutes. And the two other things are, it has to be started early in the event of PPH and preferably within 3 hours of the birth of the baby. Oxytocin is the gold standard recommended by all international and national agencies. Effectiveness is counted by how it can prevent mild PPH and moderate PPH, and also how it reduces the need for further uterotonics and decreases the need and units of blood transfusion, and it has a desired safety profile also. But the problem, as you see, is it needs the storage requirements is 2 to 8 degrees. Therefore, it needs a cold chain for transport and a refrigeration. And if you see in the table, oxytocin, methyl ergometrin, and the fixed combination, they are all equally efficacious. But the safety profile is more for oxytocin. That is why we consider it as a gold standard. When it comes to methyl ergometrin, all the nausea, vomiting, it becomes a problem, and it is contraindicated in hypertension and cardiac disease. And when it comes to misoprostol, as Shekharan said, it causes shivering and a transient pyrexia, but these are all self-limiting. When it comes to prostaglandins, that is contraindicated in asthma, but it causes a troublesome diarrhea, but again, self-limiting, and it needs a refrigeration also. And equally important, as you give the sufficient dose on sufficient time of uterotonics to control atonicity, it is equally important for you to know when to switch over to surgical management. The line between medical and surgical management is very faint, and I will give you a clue. That is, when you think of ongoing bleeding and the necessity to give the third dose of PGF2 alpha, that is 30 minutes after the first dose, that is the time you think you have to stop the medical management and think of surgical management. That is the time when you have to think of the fifth T in postpartum hemorrhage, that is, think of the theater, start thinking of shifting the patient to theater for a medical management. And when you deal with atonicity, intravascular volume replacement should be given priority, and the onset of coagulopathy. And we all have the power to save lives from Atonic Pph. Thank you all.